after today's test. So, the answer to this one is delta. So if you mark it, I'll give it to you. It's delta. This one, so 66-year-old man sustained anterior wall myocardial infarction 6 months ago. Is taking, basically, it's showing this guy's high risk, and he is secondary prevention, right? Because he had a heart attack, and his cholesterol is above 110. You just have to look at the treatment algorithm, and then you know that you're trying to get him less than 70, I believe, according to the algorithm. So he's way above goal. So the question is, what else do we do? Are we satisfied with it, like Delta says, or do we add Bravo? And the answer is add Bravo.
E.
Okay. We're not at goal. Let's step it up. And you can see the atorvastatin dose is the max dose for atorvastatin. One thing, if we were at like 20 milligrams of atorvastatin, we would have room to increase that dosage. So, but 80 is max dose for atorvastatin. We're not necessarily going to think about changing him to a completely different statin unless he was on simvastatin. Then change that shit. And it doesn't work.
Not today, it didn't.
It doesn't work. Okay.
Yeah.
So the answer to this is Bravo. Okay. All right. So why do we talk about this? In the United States, $240 billion a year is spent managing ischemic heart disease. $240 billion a year. Every 33 seconds, one United States citizen will die from ischemic heart disease or coronary arterial disease. That equates to 700,000, about 700,000 deaths annually in the United States. 1 in 5 deaths come from coronary arterial disease. So you can imagine why this is such an important thing, especially when you look at this last bullet point that says 80% of coronary arterial disease is preventable with a healthy lifestyle. We can prevent 80% of that 700,000 deaths from coronary arterial disease if our patients lived a healthy lifestyle. We talked about the risk factors for atherosclerosis with our last lecture, and they are the same risk factors that go into coronary arterial diseases because that lipid, that atherosclerotic plaque, in the vast majority of our patients with coronary arterial disease is because of that atherosclerosis. Okay? So the same risk factors for atherosclerosis are the same ones for somebody at risk to have coronary arterial disease. And we talked about how this process happens, and you get that plaque formation, and we talked about how that can then start to, especially as it progresses, we talked about how it then starts to encroach into the lumen of the artery and how that's going to affect the flow of blood through the artery. And we're going to talk about this part today. We're going to talk about that plaque disruption and that acute occlusion, or that from an acute clot formation. We're going to talk about that on Tuesday with our acute coronary syndromes, okay? And we'll talk about why there's this difference between that plaque progression and plaque disruption, and why stable angina is a plaque progression problem, okay? We'll talk about that today. But you don't need to have just a little bit of atherosclerosis in your arteries to become symptomatic. And what we find is you are fine, or a patient will be fine with 40% stenosis, 50% stenosis, 60% stenosis, have no symptoms, have no limit on their function or anything like that. Once you get to 70% stenosis, so 70% of that lumen is occluded or blocked, now that patient starts to have symptoms with exertion. Okay? So 70% of your artery can be occluded, and you now finally are having symptoms related to that. Look at that reserve the heart has in place. Okay? Now, if I have 70% and I only have problems with exertion, how do you fix it? Well, I just don't exert myself, right? But as that stenosis gets worse, and now you get to 90% stenosis, now you're gonna have symptoms at rest. So just laying on your couch watching the Super Bowl, laying in bed, waking from sleep, when you get to that 90% or greater stenosis, the symptoms start at rest. And the body is kind of in this, this tug of war on how do I meet my myocardial oxygen demand by adjusting my supply. How do I do those things? Do I need an 18-wheeler of oxygen to come in and meet my demand, or do I just need a little minivan or a small delivery van in order to meet that oxygen demand that I have at this moment? So when we look at what are the factors that could influence our oxygen supply, it's kind of a complex thing because this is the thing that we can really closely regulate, or our body closely regulates in order to adjust for this, okay? So what are the factors that affect our oxygen supply? Well, the first thing is, how much oxygen do I have in my blood to begin with? Okay? Anybody who does not have pulmonary disease and is able to breathe 21% oxygen like room air has, right, should have 98%-ish oxygen in their blood, right? That's what your pulse ox is. If they have pulmonary diseases, which you're going to study about it in Pulm, right? COPD, asthma, whatever, where that oxygen exchange is disrupted, then yes, that's going to affect your oxygen supply. Because you don't have that content of oxygen in your blood. The second factor is the rate of coronary blood flow. And this is really the key factor that regulates that supply. Because I can't make my blood 110% saturated with oxygen. I can't change that parameter, right? I can only be upwards of 100% of my hemoglobin is oxygenated at that moment. I can't go above that. So the coronary blood flow is really where a lot of our concerns are when we start to present with oxygen supply problems, right? So what kinds of things go into that coronary blood flow? Well, first of all, you have to have a perfusion of the coronary arteries. And remember, the coronary arteries are perfused during diastole, right? So I have to have a diastolic pressure that is adequate to push the blood down the length of the artery and into the myocardium, right? So I need that diastolic pressure to be adequate. Think of your patients who have severe sepsis, where now their diastolic's like 20, 30. Is that enough to really start pushing blood? The answer is probably not, right? So what are the consequences if I'm not pushing blood? Now my heart's dying, right? So you can see how having an inadequate diastolic pressure could affect your coronary perfusion. Kind of the main factor is going to be, or the most common problem is going to be your coronary vascular resistance, okay? And with coronary vascular resistance, we have to then look at two subgroups for that, okay? So the first thing that can affect my resistance, my coronary artery resistance, is external compression. So in systole, you get the squeezing of the myocytes, right? And that's going to squeeze on the blood vessels, especially those small arteries that branch off of the coronary, the much bigger coronary artery, right? It's going to squeeze on that and collapse those so that not much blood's going to get through. Okay. So what's the external compression? This is also an example of like cardiac tamponade, right? We're having all that extra pressure, external pressure exerting onto the heart. It may also affect the coronary arteries and their perfusions as well. The 2B.B thing is really probably the most important factor in all of this, because this is your feedback mechanism. So do you have local products, metabolic things that can cause the coronary arteries to dilate to increase that supply? What's the sympathetic and the parasympathetic nervous system doing? Sympathetic is going to do vasoconstriction, right? Parasympathetic is going to do a vasodilation. Okay, so what are those things doing to that local tone of the artery? Okay, so that's supply. Now let's talk about the demand side of the house, okay? Are you a triathlete who's used to competing at high levels, who needs efficient oxygen exchange, right, to be able to perform? Or are you a couch potato who just getting up to go use the bathroom or go up to the kitchen to get more food, is that a workout for you, right? So it's going to depend on that moment what your oxygen demand is. And when we look at the factors that go into oxygen demand, we look at, well, one, what's the ventricular wall stress? And we calculate that by using Laplace law, which I am not going to expect you to remember this, so please don't. But just know that there is a physical or physics type of equation that goes behind calculating that wall stress. But I'll tell you what wall stress means. When I have a pressure inside of a structure, the surrounding tissue has to work together to maintain contact with each other, right? So that it doesn't leak. But if I increase that pressure, now I'm having to work harder to maintain that contact with my partner, right? And that's what's happening as that ventricular wall stress increases. It's having to work harder, i.e. needs more oxygen, to maintain that integrity or contact with its partner. Kind of think of it as I'm holding onto my partner's hand here. Yeah, I'm exerting a little bit of effort, so I'm having to hold my hand up or whatever. But now, if they're going that way because pressure's doing this way and I'm going this way, I'm having to exert a lot more effort just to maintain that contact, right? And that's what happens as ventricular wall stress, internal pressure increases. I need more oxygen to meet my demand to maintain that contact, okay? So that's why when we talk about heart failure, the oxygen demand goes up. Because I have all that extra volume, all that extra pressure inside of the heart, it's exerting additional stressors to the heart. Heart rate, okay, it kind of makes sense. If I'm beating faster, I'm going to need more oxygen to be able to continue to work and to function, right? And then, but even contractility, increasing contractility is going to increase your oxygen demand, which kind of makes sense, right? If I take a dumbbell in my right arm and it's only 1 pound, I can easily curl that, right? Very little effort, very little thought really to that. But now let me increase that to 100 pounds. Now I'm really actually kind of having to think about how I'm doing this thing, right? One, I don't want to injure myself, but two, it requires a lot more effort. You need a lot more oxygen in order to do that because you're recruiting more and more muscles to be able to generate that lift. And that's what's going on in the heart. When it increases contractility, it increases the demand. So now that we've talked about the factors that go into what makes up supply and what makes up demand, let's talk about pathologies where we see where that can contribute to these variables changing, okay? When we talk about supply, okay, atherosclerosis, occluding the lumen of the artery, that makes sense, right? But it could be things like endothelial dysfunction, where you have an inappropriate vasoconstriction. That will decrease the flow of blood through there. Spasm, we're going to talk about Prinzmetal angina or variant angina, where you have a spasm of the coronary artery, and it makes you look like smell like, breathe like you're having a heart attack. But it's just a spasm of the artery. Tachycardia, volume depletion, so you're severely dehydrated, or you're having hemorrhagic shock because trauma. All those things will affect that supply. But looking at the demand side of the house, okay, we talked about tachycardia, the faster the heart rate, whatever. Hyperthyroidism. So now we're talking about an endocrine condition that can increase your demand. We talked about myocardial dilation, so for instance, heart failure, right? So all of these conditions can contribute to changing the supply, changing the demand, and unfortunately could lead to a mismatch where now my demand for oxygen is so much higher than what I can supply. Now my cells undergo stress or they die. So ischemia or infarct, okay? So you gotta regulate, you gotta manage that supply-demand mismatch with that. And you may be wondering, well, why is there this mismatch? And what are the consequences for it? Okay, so at the cellular level, when you are breathing oxygen and it's using oxygen for metabolism, you're in aerobic metabolism, right? You learned about that in physiology in freshman semester, right? So aerobic, using oxygen, much more efficient, produce more energy, function a lot better, right? But our cells can also function in an anaerobic state, which is less efficient. I don't produce as much ATP with anaerobic metabolism. And, oh, by the way, I have byproducts from that metabolism that are highly toxic. Free radicals, those types of things. And those will accumulate in low blood flow states, and those toxic substances will actually impact the actual function of the heart, of the myocyte. So now they're having that decreased blood supply, but now all these toxic metabolites build up, and then they, in fact, also will affect the function of those cells. When we talk about ischemic heart disease, there's so many different definitions that kind of go into this, and we're going to talk about each one of these. But if you like to see a chart or a table of this, here you go, the term and their definition. Okay, but we will talk about all of these over the course of this lecture and next lecture. But what wasn't in that chart is a couple of terms that I do think that you need to be familiar with. Okay. The first one is the concept of stunned myocardium. Okay, so what does stunned myocardium mean? Well, this occurs when you have a state where you have acute but severe but transient ischemia. So I'm not meeting my demand. I stop exercising, my demand goes down. Now that supply-demand mismatch gets corrected. Now those cells that were not getting what they needed to function start getting what they need, and then they will then start working again. Once they can kind of clear out those toxic metabolites and those types of things. They didn't die, they just were under a lot of stress because they had to enter that period, that brief period of time with aerobic metabolism. Now look at hibernating myocardium, okay? Compare that to what we just talked about, where now you have this persistently impaired myocardial function due to a chronically reduced coronary blood flow that can be partially or completely restored to normal, either by improving blood flow or reducing oxygen demand. So what ended up happening in this case is you have an area of cells that are not getting blood oxygen supply to meet the demand to function. Okay? So you're not going to have the ability for those muscles to contract and squeeze and circulate blood because they're not getting the demand that they need. But they are getting the demand they need to just live. So they're getting the basic amount of oxygen to keep them from dying. And this concept is important because when we do procedures like cardiac stents or doing CABG after somebody's had a heart attack, I'm not trying to fix the dead cells. They're dead. I'm trying to fix the cells that are hibernating and trying to get them to start functioning again. Yeah.
Would it be good to look at these two slides with the scar on being like the acute phase of this and this being a chronic?
You could think of that. Just know that this is a chronic problem, but they're not dead. They're still alive, but they're just not functioning. So if I were to do like an echo, I would not see that area of the heart moving and functioning because it's not getting the oxygen it needs to function, but it is getting the oxygen it needs to survive. Like I can eat 2,000 calories a day, and that's going to be fine for my sedentary lifestyle, right? But if I am running marathons or training for ultras and those types of things, that 2,000 calories is not going to be enough, right? Kind of goes along with this. I'm getting enough to survive, but not enough to thrive. Yeah. So when we do revascularization procedures, which we're going to talk about at the end of this lecture, when we do those, we're targeting these cells that are alive but not functioning because we want to restore function back to that diseased heart. Okay, so now let's actually start looking at ischemic heart disease. And the first one we got to talk about is Prinzmetal angina or variant angina. It goes by the same name, or it's the same condition but by two different names. But this condition is solely from the spasm of the coronary artery. Kind of think of if you had a Charlie horse, right? Hurts like hell, right? That's what's happening to the coronary arteries. You get that inappropriate spasm and contraction, constriction of the coronary arteries that's not responding to any kind of feedback, and it clamps down and it really affects the flow of blood through that artery. Okay. What can cause that vasospasm to occur? There's a bunch of stuff. It could be cocaine, it could be smoking, it could be endothelial dysfunction. But these patients will look like they're having a STEMI. But the only way you're going to know that it's Prinzmetal angina is when I bring them to the cath lab and I do my procedure to look at that perfusion. It looks wide open. There's no plaques present there. So you don't get that little narrowing. It's just the whole thing is clamped down and is just barely sending any kind of blood through. But here's an example of an EKG of somebody who is going through an attack of Prinzmetal angina. So you look at it, okay, looks fine. I don't see any ST elevation. But now they start having chest pain. You can start to see that ST segment starts to rise, right? Maybe doesn't necessarily meet the criteria yet for a true STEMI. It starts to rise, starts to get bigger, and then you really start getting that ST elevation. And now you definitely are meeting that criteria for a STEMI. But then that spasm stops, the pain goes away, and you quickly see that ST segment go back down to normal. So you'll see that in your Prinzmetal angina patients where it looks like a STEMI because you're having the EKG findings consistent with the STEMI, and because it's affecting a specific coronary artery, you're going to have a specific area of your EKG affected based on where that spasm is. So this is not going to be like your diffuse ST elevations like you get with pericarditis. It's going to be localized, so you are going to think that this is STEMI. You should activate the STEMI team and all those kind of things. But you won't know until you go do the procedure to investigate further.
Would they still be feeling this even if they take measurements?
Good question. So, how do we treat it? So nitro, in the acute setting, will stop that spasm. It causes that vasodilation, it kind of counteracts that spasm, restores blood flow, and then pain goes away. So, fortunately, this tends to be a self-limiting kind of thing, but if they happen to be in a medical facility or they have nitro on hand at home anyways, they could do sublingual nitro in that acute setting, and it will stop the pain faster than if you just let the normal body process carry on. Okay, so in the acute setting, nitro is going to be your first line agent to treat that pain that they're experiencing. But if I have a patient who has this, it makes sense that they're probably going to be at a higher risk of having it happen again whenever that spasm were to occur. So how can I prevent them from having that spasm in the first place? And the biggest thing and the best thing you can do is calcium channel blockers. Okay, I stop that spasm because I block the calcium entering into those muscles so they can't constrict.
Sir, once the pain is resolved, how sooner, I mean, if you don't run an EKG on that person, like soon enough, could you still catch it?
No. So the EKG changes once pain resolves. It's almost simultaneous, to be honest with you. So as that pain starts to resolve, those EKG changes actually tend to resolve as well.
So even if someone's going through it, you could not catch it if it was not ran soon enough.
Correct. Yeah. So you're not going to get like Q wave development. We'll talk about this in the ACS lecture. Like you're not going to get like a Q wave development 8-10 hours after the fact to be like, oh yes, you did have a heart attack. You're not going to get any of that with this because it tends to be transitory. Yeah.
Just to clarify, sir, you're going to treat the acute attack, you're going to do nitroglycerin, and after that, they're going to get calcium channel blockers to prevent
Correct.
future attacks.
Correct. Yep. Calcium channel blockers to prevent. So think of it as a prophylactic thing. Other things they could do is stop smoking. Okay. So we're going to tell that to all of our cardiac patients because smoking can trigger these spasms. If they're doing cocaine, they need to stop doing cocaine, right? Because that will stop the spasms as well too. So, but medication-wise, calcium channel blockers to prevent, sublingual nitro to treat the acute pain that they experience. Because you're going to treat it like it is a STEMI, and you're going to do nitro in a non-right-sided STEMI anyway, so you're going to treat it exactly like that. All right, silent ischemia is going to be a diagnostic conundrum because this patient is going to be having ischemia but have no idea what's going on. So they're not going to know that they need to go see their provider. They're not going to know that they need to call the ambulance. They're not going to know that they're going to need to go to the ER to get seen because they don't have pain associated with that cardiac stress that they're experiencing. And the patients that you have to be concerned about with this are, okay, your diabetics who have like peripheral neuropathy where you have damaged the sensory nerves. They may not detect that pain. Elderly patients, they start to have damage done and everything like that. They're on a lot of different medications and that can interfere with that pain perception. And unfortunately, women are more likely to have silent ischemia, which is why men have more frequent heart attacks, but women tend to die from their heart attacks. So a lot of times they have no idea it's happening until it's too late. So don't be dismissive of patients in these three categories. If something just seems a little off on them, think of a heart attack and the silent ischemia. Okay? if you have a patient who you suspect is having silent ischemia, how can you diagnose them if they don't know to present to you? And the answer is, well, let's do some cardiac testing. Let's check their perfusion. Let's do a stress test and see what is going on. Do they have EKG changes associated with their with exertion, with exercise? When I did my cardiac stress test the other day, the patient immediately before me started having ST changes in the middle of his stress test. Of course, I went next, so it made me kind of nervous. Something was going to happen, but I made it through. But yeah, he had ST changes, and I was worried that they were going to call a code there in front of me. Yeah. But so silent ischemia, Prince-Mantle angina. This is where we're going to spend the bulk of our lecture, or the rest of our lecture today, on the far left column. Okay, we're going to talk about these three parts on Tuesday, and we're just going to focus on this segment of this anginal spectrum. Okay. You can see kind of what distinguishes stable angina from the acute coronary syndromes is that plaque rupture, okay? So in stable angina, you have a stable plaque, an atherosclerotic plaque, okay? In acute coronary syndromes, you have a disruption of that plaque, it ruptures, it triggers either that part of the plaque to get sent downstream and include a smaller vessel, or it triggers the formation of a clot that then will occlude the artery. And basically think of this as, this is that 70% occlusion, and then this whole spectrum here is the 90+% occlusion, okay? So kind of going back to one of the first slides that we talked about. So we said that 70% occlusion, you have symptoms with exertion. And that's what you're going to see with stable angina is at a minimum 70% occlusion and symptoms with exertion. But it's predictable. Okay? It's a pattern of predictability. We kind of like predictability in medicine, right? We don't like unpredictability. But with stable angina, it is predictable, where I know if I walk a quarter of a mile, I'll be fine. But as soon as I take that next step over that quarter of a mile, all of a sudden I start getting symptoms. Okay? Then you're like, okay, I guess I could do a quarter mile and that'd be fine. I do my quarter mile, I feel fine, and then I'm like, yeah, maybe I'll go a little further, take that next step, chest pain starts coming back on again. Okay? So it's this pattern of predictability of your chest pain with exertion, or with things that increase your demand. So what else could it be? Well, anger, emotional excitement, eating a large meal or cold weather, so Thanksgiving dinner, right? Peripheral vasoconstriction. But this pain will come on, and then it's going to elicit a response where you're going to stop whatever activity is causing you to exert yourself and increase that oxygen demand. And then it will go better or get better and go away on its own. Or I can do it a little more quickly by giving them nitro. Okay, so I can do either, it's best for them in the meantime to stop doing whatever is causing that increased oxygen demand, that exertion or whatever, or give them sublingual nitro. But this is kind of the stereotypical description of what's going to happen that triggers an attack of the stable angina, okay? So we said exertion does it. Okay, well, he had to go up some stairs right there, and he's carrying a suitcase or a briefcase, whatever you want to call that. So he had to exert himself a little bit. He just ate. It's cold outside. There's snow on the ground. And, oh, by the way, he's smoking. And now he's clutching his chest because he's having an attack. This is Levine sign, which is the stereotypical descriptions that you're going to have with somebody experiencing like stable angina or cardiac chest pain. Now, women may not present with Levine sign. Okay, so again, have that high index of suspicion in female patients coming in who just don't look right. They look sick. Something's going on. Suspect that. The other thing that's important is when we say, oh, you're having chest pain, what does that mean? If it is true cardiac chest pain, it is not a I'm feeling stabbed in the chest kind of pain sensation, right? It's a I feel like an elephant sitting on my chest. I feel this tightness. I feel like I have acid reflux. It's a very different pain description than what you would expect. And this is important for your patients to know too, because they're like, yeah, this isn't really pain, it just feels tight. That's a concerning sign that this is cardiac in nature. Some other things you may see in your patients, especially your patients who are having silent ischemia, that should be treated as if they were having true chest pain, is these anginal equivalent signs, which is because the body, even though they're not perceiving pain, the body is seeing that there's something wrong going on in the heart, and it's trying to do something to fix the problem. So it uses the sympathetic and the parasympathetic nervous system to trigger a response to try to correct the problem. So what ends up happening because of the sympathetic and parasympathetic nervous system is, okay, you start getting tachycardia, you start getting sweaty with diaphoresis, you start to feel nauseated, you start to have some left ventricular systolic dysfunction, so you may see like an increase in the diastolic pressure. You may start to get pulmonary edema because you're not circulating that blood properly, or you have this transient fatigue and weakness. Okay, so these are anginal equivalents and should be treated as this patient is having an attack even without chest pain. Now you'll see these symptoms in patients also presenting with chest pains, but just know if you're seeing somebody sweating profusely for no reason at all, suspect heart attack. But you gotta know what your differential is, because not every chest pain patient you're gonna see is gonna be because of cardiac chest pain, right? And there's descriptions and stuff that they're going to give to you that can help you and lead you to one versus another. So, if you have cardiac causes, okay, yeah, be thinking of a heart attack, but there's pericarditis that could be going on. It could be gastrointestinal, the esophagus runs right behind the heart, right? So there's a number of things that could cause that. It could also be musculoskeletal with things like the costochondritis, I take a deep breath in or cough or whatever, and it hurts. Yeah. So there's a differential for it. So what do you do to help you rule in or rule out things on your differential? Well, I'm going to do my history and I'm going to do my physical exam, right, like we do for every patient. But then you're going to get your ancillary studies that also help you, okay? So EKG. EKG in Prinz metal angina, you may see that ST elevations, right? In somebody experiencing a stable anginal attack, so that's 70% or greater stenosis with exertion, it may be completely normal. You may have some non-specific kind of EKG findings, but it most commonly, or is commonly, a normal EKG, maybe just sinus tach because of the sympathetic stimulation. Chest X-ray may be normal, depends on kind of whether or not the lungs are affected by it. Echocardiogram, you may see an area of the function of the heart, like the wall of the heart not functioning right with your echo. But your labs are going to be important to do because you want to see how bad is this ischemia, okay? So you're going to get troponins. And we really focus on troponins. It used to be we got cardiac enzymes, which was troponins, CK, CKMB, and myoglobin, okay? So we used to get that, but what we found was the myoglobin wasn't very useful. The CKMB wasn't very useful. So they really narrowed in an effort to save money, but also improve diagnostic capabilities. We really have focused on troponin. And the reason we focus on troponin now for cardiac testing is you see myoglobin quickly peaks, but quickly comes back down, right? So what if I'm in that window where it's coming down? It may look like it's normal. I've lost that diagnostic ability if I'm looking at myoglobin. If you look at CKMB, you see it slowly rises, it peaks, and then it rapidly kind of comes back down. So again, if it's a slow riser, I have to wait, 8, 10 plus hours to be able to actually diagnose that somebody's having ischemia or an infarct. Okay, not really ideal, because I'm losing time to make that diagnosis. But you see with troponin, it quickly rises, quickly peaks, but then is slow to come down. So I have a much better diagnostic window in order to detect somebody who's having severe ischemia and infarcts, okay, by using troponin. So we found when we were doing cardiac enzyme testing with all of these things, the diagnostic yield was not very good for the other tests other than the troponin. So now we just order troponins. So how do you, if you suspect somebody is having stable angina, you didn't catch any changes on the EKG, how do you work them up? Well, if they're low risk or intermediate risk, then maybe we just need to put them, have them do a stress test and see if we can reproduce symptoms or reproduce EKG changes. Okay. Now, if they're high risk and they're having this, like we already know they have stable angina or they've had a heart attack before or whatever, if they're high risk, then let's just go ahead and do the gold standard diagnosis and treatment by sending them to the cardiac cath lab and doing a cardiac catheterization. But how do we manage our patients with stable angina, okay? And you gotta ask yourself, okay, there's a treatment for the acute problem, which is that pain that they're experiencing right now, but then there's the chronic management that we've gotta think about as primary care providers, because I don't want this person going to the ER every time they go past a quarter of a mile of walking, right? That's not gonna be ideal if they're going to the ER every day. So how do I prevent that? And that's your chronic management goals, as we'll talk about in the next couple of slides. But in the acute setting, if they present to you in your ER or in your facility, first thing you want to do is stop whatever triggered the event. Reduce that oxygen demand so that oxygen supply can kind of catch up again, right? So reduce that physical activity or whatever triggered that event. Then give them sublingual nitrates. Okay? Give them those nitrates, do the vasodilation, improve that supply to that area that's not getting enough. Okay? So that's how you're going to treat it in the acute setting. Now the chronic management, that's going to be a lot more complicated because, one, we have to give them a bunch of medications in order to address all of our concerns, okay? So when we go to treat somebody for chronic stable angina, our goals are, well, I don't want them to have any attacks in the first place. Maybe I could get them down from 1 a day to 1 a month, right? So that's one of my goals, decrease that frequency of having that attack. My next one is, okay, we said that this is stable angina, so about a 70-ish% stenosis. But what can I do to prevent that 90+% stenosis and that progression to acute coronary syndrome? What can I do to give them to prevent that acute progression? And then with any treatment that we want to do for any of our patients, the third goal is I want to prolong life or I want to improve their quality of life, right? What can I do so that that 1/4 mile, maybe I can push it to 1/2 mile. Now they can climb up climb up their stairs to get up to their bedroom on the 2nd floor, instead of them having to sleep in a recliner in their 1st floor, in their living room or whatever. So what can I do to help improve their quality of life? What can I do to improve their survival rate? So that's going to be our main goals when it comes to treating the chronic stable angina symptoms, okay? Let's go ahead and take 10 minutes, and then we'll come back and finish up.
I'm studying.
Start studying. I've heard other people saying that there's marks on your bones and thinking that way. I first thought like she doesn't want to take a GI. She wants to stay away from GI issues. So I looked at it and it's written down timeline, going down the line, and just look at the options. The one you want is that fifth line right here. That's what I researched. I didn't even think of the long but I remember yes. And I also remember it's on the last I love. Is it your pen?
I trust that. I think a lot of people that people actually make yeah, like those
Ridiculous. There were like 12 of them. I counted them because I was like, I need to memorize.
Now I know Max Joseph.
A bunch of the stuff you gotta memorize. Because it's like everything one, yeah.
When they're doing blood pressure, I just have to put in the calculator. So when you just get out of the
it really doesn't get like yeah, these are all like they're not little humans, they're their own like
yeah, we started but there's no more. As you get older, the harder it gets.
I think it was
I was talking to someone they're like, you guys had a bad day. I could always be working. That someone died. I was like, lucky man.
someone dies at someone dies
I was like, you can always be working. Second best.
No, I think it's just
tired. I'm
just to get whatever.
not good about
I went after this bike. I started with get straight up. I'm gonna get it down.
I rewatched all the lectures. And I took notes.
Not 45 minutes. No, 45 minutes. I don't know.
Well, I do parties. I do parties all the time.
And it's literally like 4 miles down the road.
Because I don't want to drive there. I would rather stay and drive my I have to drive all the way from the 5th floor to the 1st floor just to come out of the corridor. You know how much traffic there is? And that light, it sucks. I'm not gonna work together anymore.
I caught traffic all the way up. I would say.
Are now like things in service.
I have a month and a half. As long as it stays below, we're good.
Maybe.
I'm tired of that. That is clear for my
If it adds up to like that, like it's
You know what? Just my wife. It's like super sad. Yeah. They have different prices just for money, and then like you have to
When I was in Taiwan, we used to order a lot of computer things. Like I didn't know what that. So like on the phone, the app, so the menu was English. And I was like,
no, but I can say it home. Like Poland and have an
and it was whatever that would have like almost like $170 for me every day. Like it wasn't bad.
You're the point. So they take away your yes, they take away your and then you get sick. Yeah. Yeah, how about
Oh, how does that work? Because my husband was going last year. Is that going to reflect on taxes? It was. It was. The guy, whatever, combat patch, all that kind of thing. I don't know.
So when you get your pay is not taxed.
So you sure it is because he was saying that our taxes are going to be, we're going to get more money.
Shares are not taxed. It's not, even though yes,
Alright, let's get back to it so we can get you out and start your holiday weekend and study for infectious disease, right?
what
Okay, so we're talking about stable angina, we're talking about how we treat it. We talked about the acute treatment, so they're having that active pain, how do we manage it? But how do we prevent them from having the pain in the first place? How do we prevent them from getting that acute occlusion and having that progression down that anginal spectrum that I briefly showed? How do we prevent that progressing into acute coronary syndrome? And how do we improve their morbidity and their mortality and ultimately their function of life? Okay. When we look at the treatment, the chronic treatment for this, there's a number of different medications that we can use in order to address those concerns or those goals that we have. So when we talk about prevention for recurrent anginal attacks, okay, I'm thinking things like beta blockers, calcium channel blockers, organic nitrates, and ranolazine. We'll talk about each one of those specifically. But how do I prevent that acute occlusion of that coronary artery that already has, pretty significant stenosis burden? How do I prevent that from progressing to 90+% stenosed? And I'm looking at things like antiplatelets, okay? I'm going to prevent that clot from forming in the first place. I'm going to give things to stabilize atherosclerotic plaques like statins so that you don't get that sloughing off of the plaque and getting sent downstream, causing occlusion, or having the prothrombotic core exposed, causing that acute clot formation. And then ACE inhibitors can also be used, and we'll talk about why. So let's look at how do we prevent acute episodes from happening in the first place. The first line agent that you need to give your patients is beta blockers for multiple reasons. But the most important one is this is one of the few and only medications, study after study after study, that shows a survival benefit. Okay, so beta blockers provide a survival benefit. Probably a good thing, right? You want your patients to live. Let's give them things that's going to allow them to live. When you go to start them on a beta blocker, you got to know what's the dose that they need to be on. So you got to know what your goal is, right? Well, in stable angina, and I put them on a beta blocker, I want their heart rate, their resting heart rate, to be between 55 and 60 beats per minute. So if I put them on a 20 milligrams of metoprolol, and they're at 70 or 65 beats per minute, I'm not there. I can titrate the dose up a little bit more to get them into that range of 55 to 60 beats per minute as a resting heart rate, okay? I've got a number of things I can choose, a number of beta blockers I can choose in order to manage this, but you got to know what the contraindications are. And one of them is, well, if they already have a resting heart rate below my goal, I'm only going to make that worse, right? Am I really making it better by pushing their heart rate even lower, so now they're passing out or almost passing out because their heart rate's too low? Probably not. So that's a contraindication. If they have any kind of heart blocks, okay, that makes sense. Those patients should not get beta blocker therapy. If you have clinically severe asthma, okay, that makes sense. So there's a number of contraindications to beta blocker therapy that you just need to be aware of. Calcium channel blockers are second-line agents and should only be used in patients who max dose beta blocker doesn't get their heart rate down to goal, or they can't tolerate their beta blocker, okay? And the reason that these are considered second line is, what did I say about beta blockers? The only thing that provides us a survival benefit or a mortality benefit, right? Calcium channel blockers do not provide that mortality benefit. So that's why that is a second line agent, because I'm not getting that additional benefit from it. Yeah? So with Prinzmetal angina, it's because it's the spasm, and it's not this pattern of predictable symptoms because of a permanent stenosis. Okay, so in Prinzmetal angina, the calcium channel blocker is treating the specific cause of their symptoms, that spasm. Okay, in this case, what I'm trying to do is I'm trying to reduce my cardiac demand by keeping my heart rate low. Okay, so this is a different way And in this case, beta blockers is the better option because it carries that mortality benefit that calcium channel blockers do not. Okay. And the calcium channel blockers that you use in Prinzmetal angina, maybe not so much DILT and verapamil, but actually like your dihydropyridines tend to work better. So your amlodipine, felodipine, those types of things, those peen medications tend to work better because they have more of a vascular effect and less of a cardiac effect, like diltiazem and verapamil do. Did that answer your question? Okay, so calcium channel blockers, second line therapy, only in your patients whose heart rates don't get to goal at 55 to 60 beats per minute at rest with max dose beta blocker, or they cannot tolerate a beta blocker. Okay. Nitrates are going to be important, but these are not your sublingual nitrates. Okay. This is not the whenever I have pain, let me just use nitrates. This is a long-acting nitrate, which could be like Nitroderm, where it's like a topical thing that you put on like the chest and then you put a sticker over it to keep it in contact and stuff like that. But this is something that they will have continuously in their system. So it's going to have that continuous effect as far as that vasodilation, right? So if I have a 70+% stenosis that's triggering me to have these attacks with exertion, maybe I can dilate that artery a little bit so that 70% stenosis is now maybe 60%, right? I then don't necessarily have symptoms with exertion if I can open up that artery a little bit. Okay. And then the last medication that can be used to prevent acute episodes is ranolazine. And these are used in combination with beta blockers. And it ultimately decreases the frequency of anginal episodes and improves exercise capacity. So not only am I improving symptoms, but now I can exert myself more before I trigger an attack. So now I can walk that half mile, I can walk up that one flight of stairs to get to my bedroom before I have symptoms. Okay, so ranolazine can give you both of those things. This is just the different options you have and how they work, and some of the adverse effects that could be present with them if you wanted to know more about it. But the biggest thing that you have to do with any of your patients who have chronic medical conditions is you have to counsel them about the compliance with their medications, right? Just because they're on all these medications and they stop having these anginal attacks doesn't mean that they're better, right? They're better because of the medications. If they stop the medications, they will no longer be better. So they've got to be compliant with their medications. They need to make the lifestyle changes in order to prevent the progression of their disease, okay? Just because I'm on a statin does not mean I can go and eat McDonald's every day, right? I'm going to overwhelm the ability for the statin to protect me. So they got to make those lifestyle changes, and they need to adhere to kind of that strict lifestyle regimen. And then they should receive annual flu vaccines, because this is something that, if I give them a flu vaccine, decreases risk of influenza, which, what does the flu do to you if you get infected with it? Causes fevers. What do fevers do to the heart rate? Increases them, right? And what does an increased heart rate do to your oxygen demand? Increases it. And then what's that going to do if I have a diseased heart? I'm going to have an attack. So do what you can to prevent them contracting preventable illnesses. So flu vaccine as an example. Okay, so now let's move on, and now let's talk about how do we prevent the progression of this stable angina to an acute coronary event. How do I prevent that? How do I prevent that 70-ish% stenosis from becoming 90+% stenosed? Well, let me stop blood clot formation, right? So let me put them on antiplatelets, which you have a couple of options for you. So aspirin, probably the most common one, the cheapest one, right? But if they have an aspirin sensitivity or whatever, then you do have clopidogrel there to help address that platelet formation or that clot formation, and it prevents that acute occlusion of the coronary artery. Statins, so lipid-lowering agents, they stabilize the atherosclerotic plaques, so they're less likely to rupture, which we said, if you recall, I should flash the thing up for the anginal spectrum. The thing that differentiates stable angina from acute coronary syndromes is that plaque rupture. So how do I prevent that plaque rupture from happening? I put them on a statin. Okay, and it stabilizes that plaque so that it is much less likely to rupture, causing all the problems associated with it. Your diabetes glucose lowering things. So if you have a diabetic, SGLT2s and or GLP-1s will help. Okay, SGLT2s are extensively studied that show benefit, but new studies kind of coming on the market now or coming out now are showing actually the benefit of GLP-1s is about the same as the SGLT2s. Okay, but maybe long term may actually have, as we do more studies, may have a better outcome because you also get potentially the weight loss reduction things too with the GLP-1s. And then ACE inhibitors, they work great. It doesn't improve angina, but what it does is it reduces afterload, so it doesn't have to work as hard. But ACE inhibitors also have been found to reduce rates of death and further progression to heart attacks and those sorts of things. So there is additional benefit of an ACE inhibitor over just managing blood pressure. There is some mortality benefit associated with ACE inhibitor use. So those are the medications that we could use. Well, what happens if medications are not enough? What do we have at our disposal to treat those patients? Or they don't tolerate the medications, right? This is where we have our revascularization procedures, and this is, I think, where we're going to finish our discussion for today. But the two main types of revascularization procedures we can do are percutaneous coronary intervention, which is just a fancy way of saying cardiac stenting, okay? And then doing surgery where I'm doing bypass grafts, and I'll show you what that means in a couple of slides. But I'm bypassing the diseased portion of the coronary artery. And we do these procedures in patients who are on all the medications, but they just don't respond like they should. So they continue to have attacks with exertion, with that pattern of predictable exertion. They don't tolerate the medications, or they are progressing to become high risk. So we're getting close to that 90% stenosis. Then I'm going to want to do one of these procedures. Okay. So let's look at these a little more in depth. Okay. So PCI, or percutaneous coronary intervention, they're going to bring you to the cardiac catheterization suite. It's going to look like this. They're going to thread wires through an artery to gain access to your coronary arteries. They're going to inject dye, and they're going to see where the areas of stenosis are. And once they identify this area of stenosis, they can then decide to put a stent across those areas. And when it comes to stenting, there's two choices that they can make. The first is, and these are terms, and the reason we're talking about it is these are terms that we're going to throw around in normal conversation, and you just have to know what we're talking about. So you have a bare metal stent and a drug-eluting stent. Okay. So what exactly is a bare metal stent? Well, it's just a metal cage that we deploy in that diseased vessel to restore that blood flow. But what does foreign bodies inside the what do they do inside the body? They can form clots, right? Or the body recognizes that this shouldn't be there. I can't attack it with my immune cells to get rid of it, so I am going to cover it up. And what happens with bare metal stents is you place it, you restore blood flow, but then the body reacts to it, and you start getting all these smooth muscle cells kind of growing in that cage, and now you start getting a restenosis. So I've got a stent, it triggers a bodily reaction to get rid of it or wall it off to protect the body from this foreign invader, and now I'm occluding that vessel again. It takes time for it to happen, but you can see probably not what we want to happen, right? Now I don't have an atherosclerotic plaque that's occluding it. I'm actually having a occluded stent blocking that way. So they came up with this a drug-eluting stent where they put a medication that actually disrupts that recruitment and the growth of smooth muscle cells in and around the stent. So now I keep the vessel or I keep the stent open longer because I'm preventing that restenosis from occurring. Which sounds great, but all good things can have unintended consequences, right? If I'm not covering up the metal cage anymore, I'm now creating an environment where blood clots can form easily, right? And because I don't form that wall around it, now I have it for an extended period of time, blood clots can form on this stent, which then can cause an acute occlusion. So how do we counter this reaction? In these patients who get drug-eluting stents are going to be on double antiplatelet therapy for an extended period of time. So 6 to 12 months, they're on dual antiplatelet therapy. So aspirin and clopidogrel. Okay. 6 to 12 months. And I would say probably most cardiologists, as long as the patient is tolerating the dual antiplatelet therapy, will push it to that 12-month mark. Once they get to 12 months, then they just need to be on a single antiplatelet therapy, so we can downgrade them to just aspirin. But for at least 6 to 12 months, they should be on that dual antiplatelet therapy. So this is how they do the percutaneous coronary intervention, PCI. So they'll thread the wire in. They could do an angioplasty, which is they inflate the balloon to kind of open up that vessel, but that's going to have a high-risk restenosis. So we can do the stent, and this is what it looks like. So this little cage goes around this catheter, which has a balloon attached to it. It's collapsed, so I can thread it through the vessels. Once I get to where I want it, I'm going to then inflate that balloon, which is then going to deploy that stent wherever I want it. And then I deflate the balloon and then remove my catheter, and now the stent stays in place. And you can see how and what these might look like. And you can now also imagine why blood clots form on this thing, right? But here's an example of an angiography of a patient who, before they got a stent placed, you see this pretty profound narrowing present in one of the coronary arteries, probably the LAD. But then they placed the stent, and you can see how that area now is wide open. And this is a drug-eluting stent, so it's decreasing the risk of restenosis. At 4 months, it's just as open as it was immediately after the procedure. And then even at 12 months, that area is open just as much as it was immediately after the procedure. So PCI works great. In fact, in 95% plus of your patients, PCI will adequately treat the problem. But not everybody's a good candidate for PCI. So how do we know who is and who is not? Who needs to get the more invasive procedure, coronary artery bypass grafting, which requires cardiopulmonary bypass? Who needs that? Well, think of it, we typically think of people who have multi-vessel disease, so left circumflex, left anterior descending, right coronary. Maybe they would benefit by getting this CABG done. Diabetics, just because they're going to have more risks, more concerns. If it's going to affect a large area of the myocardium, so this would be like if you have a pretty high up LAD lesion, or if you have like a left main narrowing blockage, maybe doing the CABG would be better for that, to prevent that occlusion that affects the whole left ventricle. But the key word in this is graft, right? Where do we get these grafts? Well, we could get venous grafts where we're taking out one of the saphenous veins and moving it up and putting it into the chest to reconnect. Or I can get an artery, and particularly the left internal mammary artery, where I basically transect the distal part of that artery, and then I just move it down and then attach it to the coronary artery that is diseased post where that disease is. And you can see, here's an example, a cartoon example of it. So here's the internal mammary artery that they brought down and connected to the coronary arteries. And then here is an example. This would be like an example of the saphenous vein being brought, here. This is saphenous vein where they plug one end into the vessel and then plug the other end post stenosis to restore blood flow past that area of narrowing. Okay, so that's a CABG, or a coronary artery bypass graft. Here's the advantages and disadvantages of the two. Ultimately, PCI works great in a vast majority of your patients. It's less invasive. However, they do need dual antiplatelet therapy or some kind of antiplatelet therapy to prevent an acute occlusion from it. But you may be wondering, well, why do we even have a medication management for these patients with stable angina if PCI works so well, or works so great? Well, the answer to that question is they did this COURAGE trial back in 2007, and then they went back and they looked at all their patients in 2015 and updated the results of the trial, and they found that in patients who are tolerating medications, not having these side effects, their symptoms are controlled, there was no difference in outcome when compared to that early aggressive PCI. So if there is no treatment benefit of one over the other, then let's do the less invasive one, and that's the medications. So the vast majority of your patients will be controlled well enough with medications and not need that revascularization procedure for stable angina. Okay. Yeah.
So are the stents non-varicose, so they're not ruled out of MRIs?
Correct. Yes. So they will not be magnetic. Yep. So you can still get MRIs done. You can still walk through metal detectors at the airport, kind of thing. Yeah. Typically, any metal that we put into the body will be non-ferrous so that you can do the MRIs, so like titanium or something like that. The biggest concern with MRIs is going to be like other foreign bodies, like they got shot with a BB or they got shot and have a shell fragment still inside. That's when you would worry about MRIs and that. But medical grade metal is not typically magnetic. Okay. Questions about ischemic heart disease? Thanks for bearing with me on this Friday. But please enjoy the time away.